Good morning, dear professors and colleagues. I'm Changyuan Liu from Shanghai Ruijin Hospital. I'm great honored to have the chance to give a presentation on the topic of the application of adrenal vener sampling in primary aldosteronism. Today I'm going to talk about the following three parts. First, I will give a brief introduction of primary aldosteronism, hereinafter referred to as PA. The last two parts will focus on adrenal vener sampling, hereinafter referred to as AVS, including what can we do now and what could we do in the future. Primary aldosteronism is also known as Cohen syndrome. It's a group of pathological conditions associated with an aldosterone secretion inappropriate for sodium intake that is relatively autonomous from RAS system activity and potassium levels. It often produces few symptoms. Most of patients have an increase in blood pressure with or without hypokalemia. More importantly, PA will cause many complications, especially for cardiovascular and renal damage. PA has long been considered as a rare condition in clinic. However, compelling evidence have indicates that PA is the most frequent form of secondary hypertension. From the left picture, we can see the prevalence of PA was increasing with the level of blood pressure. In resistant hypertension, we can see the prevalence of PA was 17 to 23% in abroad. From a recent systematic review, in Asia and domestic, the prevalence of PA in normal hypertension patients was 5%. In resistant hypertension was 7.1%, and in newly diagnosed hypertension was 4.0%. More importantly, PA significantly increased the risk of cardiovascular events. From a recent systematic review and meta-analysis published in the Lancet study, we can see compared with essential hypertension, PA increased the risk of stroke by 2.58 times, coronary heart disease by 1.77 times, atrial fibrillation by 3.52 times, and heart failure by 2.05 times. So, PA is a very important risk factor for cardiovascular events. Consequently, diagnosing PA in the early stage of the disease and initiation with specific treatment is very important. This slide shows the diagnostic flowchart for patients with PA. I think the diagnosis and treatment of PA could be divided into three steps. First, screening. Attention should be paid to these patients like grade 2 to 3 of resistant hypertension, hypertension at young age, hypertension and hypokalemia, and hypertension and adrenal insipidoma, hypertension and long atrial fibrillation. Now we use the ARR, means aldosterone to renin ratio, as a indication for the screening test to find the candidates maybe with PA. If the AR is positive, we continue to make the confirmatory test. The most common used in clinic was saline infusion test and Cadbury test. If the confirmatory test is positive, then we could consider the third step, subtyping by AVS. Clinically, the most useful classification of PA is presented in this slide, which distinguishes between surgically correctable and non-surgically correctable forms. Adrenalectomy, when guided by AVS, almost could cure the aldosteronism and resolves or improves the control of blood pressure, and with medically better outcomes when the diagnosis is made early. So, to the aim of distinguishing unilateral from bilateral causes, also AVS is expensive, technique demanding. Now, all current clinical guidelines recommend AVS as a gold standard for the diagnosis of PA, especially subtyping of PA. So, rarely it is also used to locate and identify other adrenal tumors such as Cushing syndrome. So AVS, this slide shows the flowchart to be used to select a patient for AVS. We should know which patient should do the AVS. So the patient should seek for long-term care with surgery. If yes, we should know whether the patient presents with a large adrenal tumor and or suspicion of adrenal cortical cancer. If no, whether the patient has familiar hypoaldosteronism type 1, 3, or 4. If no, whether the patient could accept a 25 to 50% risk of having the wrong adrenal gland removed. If no, whether the patient could accept a chance of unsuccessful AVS and 0.7% risk of complications. If yes, we could perform the AVS. Before AVS, careful preparation is also essential steps. I think there are 4 tabs seen. For one, I think the enhanced CT scan should be made in order to know the adrenal position, the size, and the shape of bilateral adrenal license. Also, furthermore, the enhanced CT scan could help us to exclude the patient whether they have the renal artery stenosis. Secondly, washout. Prepare because some drugs like ACER or ARB beta blockers, diuretics will affect the secretion of aldosterone and renin. So these drugs should be discontinuation used for 2 to 4 weeks. Thirdly, hypokalemia should be corrected before AVS because hypokalemia will decrease the secretion of aldosterone. Last but not least, because of high prevalence of aldosterone and cortical co-secretary, so 1 milligram DX suppression test should be performed after AVS. This slide shows the normal anatomy and variation of right adrenal vein. We can see the typical right adrenal vein reflects directly to the inferior vena cava. However, study shows more adrenal vein variants on the right side than the left side. Like picture A, it may join proximal segment of the hepatic vein or open with the hepatic vein to the inferior vena cava. Or like picture B, there may be multiple right adrenal veins. According to our experience, more than 60% of the right adrenal vein opened near T12. More 90% of the right adrenal vein and inferior vena cava be an acute angle that is opening downward. More than 95% of the right adrenal veins open the right side near the inferior vena cava. This slide shows the normal anatomy and variation of the left adrenal vein. We can see typical left adrenal vein usually joins the phrenic vein and returns to the left renal vein. Its position was relatively fixed, so it is much easier to find than the right side. Maybe the variation of left adrenal vein was few happened in clinic. Maybe like picture A, it will return to the left renal vein directly, or like picture D, multiple left adrenal veins. In clinic, now there are two surgical approaches in clinic. One is from femoral venocentesis, the other is from cubital venocentesis. Professor John's team first reported the cubital venocentesis in the world. The success rate of AVS from cubital was about 86.7% and is widely used in China. This slide shows the types of right adrenal vein according to AVS. From left to right is glide-like type, delta type, triangular type, and spidery type, and the irregular type, respectively. Also, we should know some reasons for the failure of AVS because we couldn't success every time. The failure of AVS often happens in the right side. For the right side, maybe the branch of the hepatic vein was mistaken for the adrenal vein. Also, the accessory renal vein may be mistaken for the adrenal vein. Or incomplete insertion resulting in a dilution of the blood. For the left side, the main reason was a dilution after phrenic vein intersection. So the blood maybe we can't see the successful of the AVS. The complications of AVS. The only major complications of AVS is adrenal hematoma caused by rupture of adrenal vein, maybe bleeding, dissection, thrombus, infection, and so on. It's the rupture of adrenal vein characterized as a sudden lumbar pain persistent after or during AVS, but this complication could be resolved after a few days conservative treatment. And in the AVIS study, the prevalence of these complications happened only about 0.7%. So, and also it may be often happened in the right adrenal vein than the left adrenal vein. Whether should we stimulate with ACTH still is a controversial issue. From our study in Canada, we could see 28% of the patients changed the result. About 72.7% from unilateral became bilateral after ACTH. 20.5% patients from bilateral become unilateral after ACTH, and 6.8% patients from one side to another side after ACTH. So also ACTH stimulation during AVS facilitates the assessment of selective adrenal vein catheterization. However, there is no conclusive evidence that ACTH stimulation leads to a better outcome than unstimulated ACTH. This slide shows the indexes currently used for the interpretation of AVS results. Now the first and the last means selectivity index and the lateralization index was most used in clinic. The SI is the most popular technique to confirm the success of AVS. If the values above the cutoff confirm that the sample was obtained in the adrenal vein. The lateralization index is an index to be used for assessment of lateralization of aldosterone exercise. The values above the cutoff indicates that laterated aldosterone exercise. But now, different countries may have different cutoff values for SI and LI. The suggestion was made to use of SI cutoff of 2.0 or greater for AVS performed under unstimulated conditions and 3.0 or greater for AVS performed during ACTH stimulation. Also, the suggestion was made to use of LR cutoff of 2 points or greater for AVS performed under unstimulated condition and 4.0 or greater for AVS performed during ACT stimulation. In China, we used the SI over the cutoff of SI over 2 point, and the LI also point cutoff was 2 point. The last slide shows what could we do in the future. Maybe because there is no dedicated casters for AVS at present, so we hope to develop the specialized caster for AVS according to clinical needs. Also, the Danner CT could show the angiography and soft tissues at the same time and reveal the communication when around the adrenal gland. Maybe it could improve the success rate of intubation of AVS. Lastly, take from the microcaster could take from the membranes of the adrenal vein to more accurately assess adrenal hormone secretion. In summary, first, PA is widely recognized as the most common form of secondary hypertension. PA increased the risk of stroke, coronary heart disease, heart failure, and renal damage. Secondly, the diagnosis of PA from screening to confirmatory to subtyping. AVS is the gold standard for the subtyping of PA, especially for guiding the treatment strategy. Last, it is safe and effective via the cubital. The experience and proficiency of the physician are related to the success of AVS. Now, there are still some controversial issues need to be solved. Thank you very much.